Good morning. Thank you for asking me to come and talk. So happy World Sleep Day, by the way. Today is World Sleep Day, which I think is the original reason we chose today for this. So today is the day when we think about the importance of sleep. As I said, my name's Mike Farquhar. I'm a consultant in sleep medicine just across the river, Evelina London Children's Hospital, part of Guy's and St Thomas's NHS Trust. My day job is trying to help kids with complex sleep difficulties, but I've done a lot of work since I became a consultant 10 years or so ago about exactly what we're here to talk about today, the impact of fatigue, which is very much related to sleep and sleep deprivation and sleep biology on the way that we work when we have to work 24 hours a day, 7 days a week, 365 days a year. Do you normally get enough sleep? I can be reasonably confident that no matter who I'm asking that question to, that probably not. We know that when we look at adults in a country like the UK or similar countries, that you are probably missing about an hour of sleep most nights of your life. As adults, you probably need about 7 to 8 hours of sleep most nights of your life. You're probably getting about 6 to 7 hours. Doesn't sound very much. There's lots of coffee, keeps you awake, everything's fine. But if you think about that in a slightly different way, if you're missing an hour of sleep every night of your life, you're missing the equivalent of an entire night's sleep every week of your life. And sleep, as the theme of World Sleep Day today, is absolutely essential to your general health, well-being, both physical and mental health, well-being and functioning. And if you are starting from a point where people are probably missing that amount of sleep every week of their life, it puts them more at risk when we start to think about fatigue, particularly when we start plugging them into rotas and things that are going to make that even worse. So when we're thinking about our colleagues working around the clock, we start from an assumption that they are probably sleep deprived already. Why does that matter? Why is sleep important? I can literally stand here and talk about that all day. There's a lot of common belief that nobody knows what sleep is for. It's just this weird thing that we do. We actually understand an awful lot about why sleep is important, and we're constantly learning new things about what sleep is doing for us every night as we sleep. But the simplest and most straightforward way to think about sleep is that if you think about your brain and body as a piece of complex machinery, like a car needs regular repair, regular maintenance to continue functioning at its best. If you skip the repair and maintenance, the car will start to develop problems. The longer you skip the repair and maintenance, the more problems develop, the more complicated they become, the more expensive they get to fix. Sleep is doing this for you every single night of your life. It is that essential role of regular repair and maintenance that is keeping your body and brain functioning at its best. Skip the repair and maintenance, problems will start to accumulate and develop. There are other bits of sleep biology that really tie into this. I am sure you probably will have had the experience at some point in your lives of being jet lagged. Jet lag is that really uncomfortable collection of signs and symptoms that come when your brain and body are trying to function at a different time to the time zone that you happen to be in. And that relates to a really fundamental piece of sleep biology called our circadian drive, or our body clock, that is trying to keep us, generally speaking, awake in the daytime and asleep at nighttime. There are lots of things that tie into that from a physiological basis, but we break it down to this kind of simple conceptualization of how alert or awake we feel at any point in the day. The orange line in the middle here represents an average kind of feeling of alertfulness as we go through the day. At this time of the day, hopefully you've all woken up, you're feeling a bit alert. You'll probably maintain that alertfulness. You will all probably have a little bit of a dip just as we start the workshops this afternoon in your level of alertfulness that then usually increases as the day goes on until you get to bedtime, and then it drops off and off you go to sleep again. There are two core concepts that affect that orange line in the middle. Along the top is what we would describe as sleep load or sleep pressure. This is like hunger for sleep. The longer you have been awake, the more you need to sleep. And this builds up linearly. Every moment that you're awake, you build up more of a need for sleep, and it carries on building up. But we don't feel progressively more tired or sleepy with every passing moment of the day. And the reason for that is that sleep pressure is countered by what we call the circadian alerting signal. This is like Red Bull from your brain. It's a signal to try and keep you alert and awake that as the day goes on, increases in strength to keep you awake and functioning when you are meant to be doing that. The reason for that lag in the middle of the day is that the alerting signal just doesn't quite keep pace with the increase in sleep pressure. In the evening, it goes into overdrive to counter and then drops off at bedtime, which is what helps us to get to sleep. In the context of what we're thinking about, where we started thinking about this work, which is very much about night shift workers, the key point is that in the middle of the night, that alerting signal is zero. At 3 o'clock in the morning, every single cell in your brain and body is telling you that you are meant to be asleep. And when we are thinking about organizations that have to provide critical care at those times, that has a really big impact on how people are able to do those jobs. What that means is that when we're thinking about people working at 3 o'clock in the morning through the night, physiologically that is like asking somebody to work when they're jet lagged. And we wouldn't really expect somebody to get off a plane from Sydney and plug them straight into a working rota. But when we work nights, physiologically, biologically, this is what we're asking them to do. And historically, the NHS has been phenomenally bad about taking that into account. There is lots of evidence, as Laura alluded to, that looks at the impact of this. We don't have the time to go into all the details of this as we come through, but what it boils down to is that when we ask people to work around the clock, we know that this is bad for their health. It increases their risk of physical health problems. It increases their risk of type 2 diabetes, of obesity, of anxiety, depression, Alzheimer's disease, some types of cancer. It's a lovely list, cardiovascular disease. And this is a fundamental consequence of asking people to function against these biological rhythms. We have a responsibility to be aware of that and to compensate for it for the people who should be working supported by their employers as we do so. One of the key things that we're here to talk about today is how that impacts the ability of people to do the job they are there to do. When we look at how people perform in the middle of the night in high-risk environments, this is data from a paediatric intensive care unit down in Southampton. When we look at the decisions that people make, when they are tired, they make riskier decisions. They actually make them with just the same level of confidence as they would make safer decisions when they're not tired, which actually makes the whole situation even more dangerous. In a paediatric intensive care unit, a risky decision can have a huge consequence for the patient that we are looking after. So we have to be aware of this and how we compensate for it as we work. It's really simple. None of the basics behind this are particularly complicated. There's a huge amount of very complex sleep physiology and biology behind all of this. But it boils down to these really basic, simple points. If you've got a tired healthcare worker at 3 in the morning, they're more likely to make mistakes. And in these environments, mistakes have a critical potential consequence. We started, as I said, looking at night shifts, but actually the more that we did this work, the more that we realised that fatigue is not really just a night shift problem. This is data from the GMC survey from a few years ago that asks our trainees and their trainers lots of questions about their working conditions and environments. And what they told us at that point, this is from a few years ago now, I'm sure this figure would now be higher, 20% of doctors regularly feel tired in the daytime to the extent that they think it affects their ability to do their job. Fatigue is worse at night, but this is a 24-hour problem. Industry, as we're going to spend a bit of time today learning about other industries, we know from data from other industries that if you work over 8 hours, your risk of having an accident, making a mistake, goes up. We also know that if you then continue to work between 8 to 12 hours, the risk of an accident or mistake goes up even further, maybe as much as double. We work in an environment where many of our staff are still working 12 to 13-hour shifts. And it means that if we do not think about how to modulate this impact well, that these risks accumulate and the consequence for the care that they are there to deliver can be really quite significant, particularly if we don't have that situational awareness of them. In sports medicine, they use this kind of concept a lot. This is the performance curve. So along the bottom, you've got stress, pressure, arousal, however you want to think about it. Up the y-axis is performance. If you're a professional athlete, you will know that if you train and train and train and train and train, you get to a point where your performance stops improving. And actually, if you overtrain, your performance will drop off. So athletes spend quite a lot of time making sure that they train to maintain themselves circling around the top of this curve. In an organisation like the NHS, historically, we have given our staff the impression that no matter what the pressure is, how many people there are to be seen, people to do in the operating room, whatever, number of jobs on the list, we expect people to keep going, and we give them the impression that their performance should continue along that dotted line on the top. But all the evidence, all the data tells us that's not what happens. When people are continually pushed without thinking about how they modulate their effort, their stress, their performance, then things will crumble. Things will start to fail and not function as well. But we continue to give people this impression that they should maintain a level of performance that is not biologically possible in a context like this. There are other consequences. A large part of this work, when we started doing it, was focused on the fact that we know that there is a significant risk to staff of having a personal accident. In this country, we have a very changed attitude to drink driving from when I was a kid to where we are now. Lots of campaigns around about it. I grew up in the north of Scotland in the 80s. The attitude to drink driving was a bit like this. As long as you weren't absolutely paralytic, you're probably all right to drive home. The attitude to driving now is this. If you've had any alcohol, most people will hesitate to get behind the wheel of a car. The reason for that is even a small amount of alcohol will impair your reaction time such that your risk of having a significant accident goes up quite significantly. When we look at sleep and fatigue, if you have been functionally awake for about 16 to 18 hours, your reaction time will be impaired to the same degree as if you're at the legal drink driving limit. And staff who have been working shifts in a hospital will not think about fatigue in the same way. They wouldn't get behind the wheel of a car if they downed a pint of beer before driving home, but they will get behind the wheel of a car if they are tired, because they don't think about it in the same way. But they are just as much at risk as if they were at the drink driving limit, and probably more, because again, they don't have that situational awareness that this is actually something that might have an impact. And that means that once every 6 to 7 months or so, we hear stories like these. They make the local news, they never make the national news. These are doctors, nurses, healthcare workers who crash and die driving home after a night shift because they fall asleep behind the wheel of a car for a few seconds. And a few seconds at 70 miles per hour on a motorway is a catastrophic outcome waiting to happen. Deaths like these are what catalysed me to start doing this work 10 years ago. I'm sure Emma Nancy will allude to the fact that that's what drove them to get involved in this campaign a few years later. And what we are trying to do is to make people aware of these risks. The patient safety aspect is absolutely huge and a really key part of it, but we also have a huge responsibility to be making sure that we're reducing the personal risk to the people that are delivering that care as much as we possibly can. So that very quick run through in terms of sleep physiology, biology, the impacts, how all this interacts, made us think that we should be stopping and thinking about how we do this better. Laura alluded to the fact that there are different strands to this, and because it was the easier way to start doing this, when I started this work, I focused on the individual elements. I took our new junior doctors, our student nurses, and we gave them an hour lecture on sleep, tutorial on basically how to manage their sleep. We spoke to them about how to improve their bedrooms, how to think about their core sleep, to try not to be sleep deprived all the time. We spoke to them about working through the night, tips and strategies to manage the impact of night shift working, how to recover from that. And it gives them a kind of a toolkit for trying to minimize the impact of sleep, sleep deprivation, working around the clock on their own personal safety and well-being. When we look at the outcomes from that, about 3/4 of the people that we've done that teaching with came back and said, yeah, do you know what? Nights are not brilliant. I don't love working them, but I've learned something that means I've helped to make it better. The really, really important point about this, though, is that this is individual-focused work, and you can be absolutely perfect at putting all of these things into practice, and there will still be a significant impact. It is not an individual responsibility to deal with fatigue in the workplace. It is a systemic responsibility. And whilst we can teach individuals things that make that better for them, it is absolutely not the case that this is the only thing that can and should be done. We see that in the context of healthcare. This word is a bit of a dirty word in medicine. Resilience, this kind of idea that we just teach people to cope better, everything will be fine. And it's a really damaging construct sometimes. There are lots of positives. Me teaching people about sleep is resilience teaching. But it's a really damaging concept when people get the impression that that is their responsibility. Just you improve, you cope better, and everything will be fine. We saw that very much reflected through the pandemic in this lovely idea that we all got, the clapping and all the rest of it, about how amazing NHS staff were through the pandemic and are before and after the pandemic. But there's this kind of translation of that into this concept that NHS staff are somehow better, that we're superhuman, that we're able to do this in a way that other people can't. And we're not. Our physiology is just as boringly normal as everybody else's, and we suffer all the same consequences as everybody else. But this, the more that this is in the public culture, it sets an impossible standard. If you are an NHS nurse working around the clock, you feel that you have to reach these standards. And if you don't, if you can't do 120%, you feel like you failed. And that's the wrong way to be thinking about this. So NHS staff are not superhuman. And this is a really subtle but corrosive aspect of NHS work. It also means that resilience is only ever part of the solution. The flip side of this, when we look at measures of the consequences of this for our staff, is that burnout has been a huge problem amongst the NHS staff for an increasingly long period of time. This is the consequence. When people are pushed beyond their limits, we see all of that happening. People stress leave, leaving work, changing professions, because it is just impossible to maintain that level of performance without there being a consequence on the individual. largely through work that Amit and Nancy were involved in terms of lobbying the GMC. We've started to look at measuring burnout in doctors, mainly junior doctors, trainees, but also the trainers that trained them. And it's a kind of a relatively top-level way of asking about burnout. But there are burnout measures included in the regular surveys that we ask about, and those measures are all increasing. We have an increasingly stressed workforce who are trying to continue to deliver the best possible care that they can offer with resources that are not matched to that need, and that is a huge problem. That issue of burnout is one that it doesn't really matter. So this is through the years for trainees and trainers over the last 5 years in terms of burnout. The blue and orange towards the left are the high and moderate risk of burnout. In our current NHS workforce, 62% of our trainees, the junior doctors who've been on strike for the last 3 days, they're the ones that actually provide the bulk of the care around the clock, a lot of the time from a medical perspective. 62% of them are felt to be at high or moderate risk of burnout, and the consultant colleagues that train them, 52%. These are not small figures. This is a huge problem, and it all comes back to lots and lots of factors. But these kind of issues, fatigue and the impact of working in this way, is a really key part of that. As you'll hear from Emma and Nancy, a lot of the work that they've done has been focused on anaesthetics. Anaesthetics is an amazing specialty, and they have done a huge amount of work that no other specialty would have done in the way that they have over the last few years to do this. But they're a really lovely specialty in lots and lots of ways. And when we look at their trainees relative to other specialties, their rates of burnout are in the lower half. We can be pretty confident that the data, the things that Emma and Nancy are going to talk to you from an anaesthetic perspective, everything is probably worse in many of the other specialties that is out there. We don't need to go and ask them all to know that, because we can see it reflected in data like this. There are things that we think organisations can and should be doing. Across the river, a few World Sleep Days ago, we launched a campaign called Halt, Take a Break that was intended to change the way that we think about rest and breaks in the context of an organisation like the NHS. Those of you who've worked night shifts in the NHS will know that it's sometimes seen that the break is a luxury. It's, oh, I got a break, that's a bonus. We try to change that idea and say that actually the rest and breaks are essential to the care that you deliver. If you're not getting regular rest and breaks, you're not delivering care to the standard that an organisation like Guy's and St Thomas's alludes to. It's not as simple as sticking up a few posters and suddenly everything changes, but it is a way to try and change that culture of thinking about things. The junior doctors contract, the last reason our junior doctor colleagues went on strike a few years ago, bit controversial, but actually it does have some key points. The junior doctor's contract makes it very clear that if we don't get the working hour limits and protected rest that we should, that both patient safety and the safety of the doctor are at risk. We've done work with organisations like the BMA to try and make these points. So every hospital in England is signed up to the Fatigue and Facilities Charter, which talks about things that can and should be done to support staff. And again, as Emma and Nancy will talk about, the anaesthetic colleges have come together to do a huge amount of work as part of the Fight Fatigue project to think about how we can do this better. When I started as a medical student, I was told to go and read The House of God, which is a book all about being a junior doctor in America in the 70s. It's very time and space specific, but actually a lot of the general themes still come through. From my point of view now reading that book, the thing that jumps out is the character that says, how do we care for patients if nobody cares for us? And this was a concept that was missing from the NHS for a very long time. Pre-pandemic, we were just starting to get to the point where it was starting to come back in again. Health Education England published this in early 2019, so looking at the mental health and well-being of NHS staff, and they asked that question, who cares for the people, who cares for the nation's health? At the end of 2019, so immediately before the pandemic hit us, the GMC commissioned this report by Michael West and Denise Koya looking at the things that affect the health and well-being of doctors and medical students. And one of Michael's top-level quotes in that was this: we can't go on the way we are, loading more responsibility onto doctors already struggling to cope. Where workloads are excessive, patient care suffers, and fatigue is a huge part of that. That report has lots of recommendations, and because people like me were involved in doing it, there is a heavy focus in that on things like getting rest and sleep and thinking about rota patterns that make sense from a circadian body clock rhythm. What can we do then to think about this? You will hear lots today about things that we can think about to try and make this better. We have to continue to work with the top-level organisations to raise the point, to make these issues on people's radar and link them to these fundamental aspects of what we are and who we do. I think every organisation within the NHS should be teaching its staff these basics. What is sleep? What is sleep deprivation? What is fatigue? How can you work around the clock? And I think we should be looking at things like organisational culture to rest and breaks, which, as you'll hear as we go on, are absolutely critical. There has been a renewed focus on staff well-being as a concept in the NHS through the pandemic. There's a lot of amazing work that's been done under that badge, but we have to be really careful that it has to be meaningful. We saw things like this, gesture politics. I'm an NHS member of staff, I have the George Cross. I don't really want the George Cross, I want my rest and breaks, thank you very much. I want enough staff to be able to do that. This is lovely, but meaningless. So when we talk about well-being, we have to be really clear what that means and how it translates. You will hear today about fatigue risk management systems. We should be using these in the NHS, but we don't have a culture where I think it's safe to do this. Because as Laura alluded to, a lot of the time when we raise fatigue as an issue, it becomes a personal performance issue. The NHS is not a safe environment, and we need to think about how we apply this within the NHS. The last point, though, when Mr Hunt was on the back benches and chairing the Health and Social Care Committee, he looked at a report that looked at the current issues in NHS staffing and all the rest of it. It's clear that workforce planning has been led by the funding envelope available to health and social care rather than by demand, and the capacity required to service that demand. What that means is we don't have enough staff, we don't have enough resources. We continue to try to do the job that we're here to do, but increasingly we are doing that by drawing on our own personal reserves and burning ourselves out, because he admits there just isn't the resources there to do what we need to do. When we look at that, this is a report looking at maternity and neonatal deaths. We see that reflected in things like this. So staff are working flat out, they're doing their best, but they're stretched to the limit. And when staff in environments like maternity and neonatal care are stretched to their limit, the consequences are catastrophic. The Academy of Medical Royal Colleges looked at this at the end of last year and again said the same thing. This is a really political thing for the Academy of Medical Royal Colleges to have done. We can no longer stand by while others seek to normalise the unacceptable when it comes to health and care. This is normalising the unacceptable. The more we don't think about the impact of fatigue, the more we are continuing to ignore this huge elephant in the room. And that means that it comes down to safe staffing and all the rest of it. And that, this week, has been very clearly demonstrated by our colleagues on the picket lines. They are there not for selfish reasons predominantly. They are there to highlight the fact that the NHS that we are working in is on its knees, and a huge part of that is to do with issues like this, where fatigue really impacts our ability to do our jobs safely for both our patients and ourselves. I think I did that bang on time. I don't know if there is time for questions or not.
Thank you, Mike. So I always gain something a little bit more every time I listen to you, and I've listened to you a few times now. We've got time for a couple of questions. We're taking, brilliant, one from the floor, and then we'll take from one online. Thanks, Mike.
So if you could just introduce yourself for our audience online, please.
Jackie Williams from the Nursing and Midwifery Council, but I want to talk really from more of a personal perspective, Mike, because I'm very, very familiar, being married to a pilot, what the restrictions are. And those restrictions are absolutely mandated. You know, a pilot is not allowed to work more than so many hours. They are not allowed to even sleep in a certain place. There's very much restrictions from the CEA, which I'm sure we'll hear. So, and whilst actually individual responsibility is key, it is the systemic.
And that's very much the point of today, is that we are hoping to bring together people so that we as NHS staff can learn from other industries at exactly that point, yes. Why are we so awful at doing this when every other safety critical industry is so much better?
Thank you very much. I'm going to go over to Rich, who has a question from online.
Good morning, Mike. Thank you very much for that. Lots of chat online. There's been a couple of comments about things like the thorny issue of 12-hour shifts, but also people who work on permanent night shifts, and recognising what you've just said about the safety implications, but the fact that some people can be quite wedded to either night shifts or longer shifts. And so whether you've got any sort of thoughts on how you can help encourage people.
I've got lots of thoughts on that, most of which are probably not going to finish time I have available. When we look at other industries, from a health and safety executive point of view, 12-hour shifts in a high-pressure critical environment overnight are deemed not sensible, and they would recommend shorter shifts. The problem with the NHS is if you take the current working staff that we have and say you have to work 8-hour shifts instead of 12-hour shifts, which might be better from a sleep biology perspective, all the impact of managing all this, but if you don't immediately increase the number of staff by about a third, then actually all you end up doing is shifting people around the clock more often, and actually that's just as damaging in many ways. So yes, we should be thinking about this. Emergency departments are increasingly shifting to 8-hour models. And I think the people that prefer to work the longer shifts, we probably need to continue to have the conversation where there are often personal reasons for that, but the scientific evidence and the impact for both them, but also their patients, and being honest with them and saying, look, we know that there might be advantage from your perspective, but there are hidden risks and clear risks that we should be very much clear about talking about. I'm happy to talk about that separately if anyone wants to grab me one way or another. I'm on Twitter, so that's a good way to try to find me. Right.
Thank you.
Welcome.
Brilliant.
Thank you very much. And as we said earlier on, please do continue to add your questions online. And for those of you in the room, please write your questions on little post-its and put them on the flip chart at the back so we can capture them from after the event. So just give us 1 minute as we move on to our next speaker.
Thank you, Andrew. So I'm going to introduce our next speaker, and I have great pleasure to introduce Emma Plunkett, who is a consultant anaesthetist at the University of Hospitals Birmingham and Birmingham Women's Hospitals. And she has non-clinical interests. She's been championing the area of staff support and well-being to help them perform. And ultimately, she's also championed a lot of the work, and she's co-chair at the Fatigue Group, which is a partnership between, correct me if I'm wrong, the Association of Anaesthetists, Royal College of Anaesthetists and FICM, looking to improve the culture of fatigue and leading the way on the Fight Fatigue campaign. Thank you.
Lovely, thanks Laura. Hello everyone, it's a real pleasure to be here. So yes, these are the two hospitals that I work. So I'm an obstetric anaesthetist, and I know we've got lots of midwifery staff. I've seen on the chat, it's addictive watching the chat actually. The point that Mike just made about safe staffing, I've been clinical quite a lot of this week, and we never seem to be at safe staffing levels. Actually, I think we're supposed to have 14 midwives. There were 6 the other day on the shift. So it doesn't really feel like things are getting better. But hopefully today we'll come up with some solutions. So I'm going to talk about how it feels in healthcare, and I'm going to share some of the published data. So we have done a lot of work in anaesthesia, as Mike said, to describe the scale of the issue of fatigue. So I'm going to present the data that we've collected, but I'm going to put it in context, and I've got some data generally from healthcare staff, from other specialties and from nurses. And interesting, I picked out this BBC report as well that I saw in Mike's slide. There's a little bit of lovely overlap, hopefully kind of seamlessly flowing from one presentation to the other, because I'm a clinician, I work in healthcare, and I certainly experience fatigue regularly, and these headlines kind of resonate with me. I have a role as a college tutor for the college. I supervise a lot of junior doctors, and it feels like every day I hear about someone else who's having a period off work with burnout or experiencing burnout. So things did get a little bit, weirdly, a little bit better, that focus on well-being during the pandemic, but it feels like now we are really kind of suffering the consequences of that. So I think this meeting is incredibly timely. And I just thought I'd mention this because as I've kind of learnt more about fatigue, I think there are sort of 2 types of fatigue, and this comes from a sort of personal experience rather than any kind of great expertise in this, but there's the kind of sleep deprivation that comes from our shift patterns, our long shifts, our general sleep habits outside of work, not getting enough sleep. But then there's this we're all trying to do more work in the same time. And I do a pre-op clinic, and I see my patients, and then I have a stack of notes to look through at the end of the clinic, and I find it increasingly hard to make decisions. And I think this idea of decision fatigue is really common in healthcare. And actually there's some interesting published data, and there's some work I think going on around the country, but particularly I've been in touch with the team from Aberdeen around this, that actually people's decision-making changes the longer it is since they've had a break. And actually these are 2 examples of more conservative decisions, and I wonder if this is, and I think I see that as well, that actually I'm more likely to just say, actually I need to see this person face to face, which has kind of resource implications, perhaps the longer it is since I've had a break. So these are, I'm going to go through some of the published data. So it is quite data heavy, I'm afraid, but I think it does really help us to kind of get the context of where we are in healthcare. And I'll start with this. So this is from the general population, the Great British Bedtime Report. And they haven't updated it, actually. I was hoping for an update, but this is from 2017. And it echoes what Mike says. Very few of us get adequate sleep per night anyway. And quite a large number get sort of less than 5 hours sleep a night, which is really kind of scarily low levels of sleep. But about a third of us sleep poorly most nights. And there was recognition here of the impact of that on our work performance. So yes, as Mike says, I agree, we're probably all to a degree already sleep deprived. The NHS staff survey from last year was published last week. And this is the kind of headline statistic from the health and wellbeing session. So almost half of staff have felt unwell as a result of work-related stress in the last 12 months, which is an incredibly high number. It's down a little bit since last year, but I don't think this is any reason to be kind of complacent. So this is from all groups of staff. So remember, Mike spoke a bit about levels of burnout in trainees and trainers. So this is from all healthcare professionals. So this gives us an overall picture. About a third of staff feeling often or always burnt out because of their work. And you can see the other numbers there. You know, almost 40% find it emotionally exhausting. People don't have enough energy for family and friends. And 2 in 10 feel that every working hour is tiring for them. And people don't feel, generally, well, some people do, but a lot of people don't feel very supported by their organisations on their health and wellbeing. And I think we have improved that recently in that we talk about it a bit more, but I'm not sure we're actually doing things that change management. I've worked in this area for a long time, and I still found myself a couple of weeks ago having to try to convince people to give us some rest space for our doctors on intensive care to have a nap on a night shift. It feels like I'm still coming up against barriers, despite having all of this evidence. So this is a summary, and I'll talk through some of the key points from a survey that was done after the death of Ronnie Patel, one of the faces that you saw on Mike's slide, who died after a run of night shifts in 2015. He was on his hands-free kit singing on the phone to his wife, who was pregnant at the time. And I was a member of the trainee committee at the Association of Anaesthetists, and it often takes a tragedy, doesn't it, to kind of really kind of bring about change. And when we felt this tragedy, we wanted to do something differently. And as you've heard this week, trainees are good at standing up for themselves. And we did a national survey of trainee anaesthetists with responses from all over the country. So I think 100% of hospitals, there was a response from there. And they recognised the impact of fatigue on their kind of physical health and well-being. This isn't terribly surprising, I don't think. This is worrying, to say the least. 57% admitted to having had an accident or near miss post-night. Some people won't have felt comfortable to say that. And trainees have long commutes. That's what's unique about them. They rotate around the country and they drive long distances, and they don't have control over where they work necessarily. About 2/3 had access to on-shift rest facilities, not dreadful, but nowhere near what it should be. And about a third only had access to post-shift rest facilities, but people don't like using them. And this is something that we're trying to change, this idea that people just want to Nancy called it get-home-itis, I think, just wanting to get home at the end of your shift and rest. And I think we're trying to change the conversation and prompt people, are you safe to drive home, to kind of encourage people to rest where needed. Most people recognise they didn't get uninterrupted breaks on night shifts. They didn't sleep well between night shifts. I think once I had kids, I slept better when the kids were out the house on a night shift. But often people find it very difficult to sleep between nights. And as I said, most don't sleep before driving home. Mike wrote us a lovely editorial about this, and it highlighted what he said already, really, that actually not only do we need to focus on individual strategies, but we need support from employers. And that what our survey did was change what was previously anecdote and could be dismissed in the kind of, it was in the news for a day or so and then it was gone, into some robust evidence, and reminded us that we really need to look after ourselves. So we presented the data, and obviously our consultant colleagues, I think I was transitioning to a consultant at this point, said that, what about us? So we've surveyed consultants and staff grade doctors as well. And we asked slightly different questions, but most of them, I'm surprised it wasn't all actually, reported work-related fatigue. But the interesting thing about it was that 50% said it had a moderate to severe negative impact on all aspects of their kind of health, well-being, ability to do their job. So it's really describing the impact of fatigue on it. We looked at how interrupted they were. So consultants work on call patterns, so a day and on call, and then potentially another day after that. About 50% received several calls overnight, and interestingly, quite a lot of people, myself included, struggle to go back to sleep after that. Yet you've not been in work, so your trust would suggest that you maybe have to come in the next day despite having quite an interrupted night's sleep. Very few received the recommended 11 hours rest in between kind of on calls, and quite a lot of people, about a quarter, work in a department where they don't have a plan for covering you if you've been up all night, like covering your clinical duties the next day. 3/4 do, which is good, but again, still work to improve. And almost half reported a car accident or near miss, mostly as a trainee. I think it was about 1 in 10 as a consultant. We asked about causes of fatigue, and you can see a range of responses here. So again, it's lack of access to breaks, it's staffing. This is done 5 years ago now, so I think the staffing levels are worse. I'm more frequently asked to cover my trainee colleagues as well as my consultant colleagues. The clinical workload is going up, and there is this ongoing pressure for non-clinical workload as well. We had an editorial, and I think there's a link to the editorial in the resources from today, written by Drew Dawson and a colleague, identifying some of the issues. And I really like this. It was quite sort of controversial, and it made me think really that ideally, of course, we'd have wonderful staffing levels such that we could all have plenty of time for breaks. But as they mentioned, they're tried and tested solutions for which the likelihood of implementation is close to zero. We don't live in that world. But it doesn't mean that we shouldn't talk about it, and I think that's been what's happened previously. This is a difficult issue, so actually we've tried to pretend it doesn't happen and just kind of crack on with things. And we know that organisations need to recognise this, and I think we're maybe starting to get that, and this is what today is about a little bit more. And then potentially an incredibly controversial thing to say, arguably in the vast majority of cases, a tired doctor is better than no doctor at all, because we have to work when we are tired, because nobody is ever going to feel their best, as you've heard from Mike, at 3 a.m. in the morning. And actually, I was receiving some emails this week where the obstetricians, they plan a ward round at 3:30 in the morning on delivery suite. And I was just, I'm in sort of two minds about that. Is that because you're tired and you're double checking, or is it because actually that's just the middle of the shift? So we need to think carefully about how we're kind of strategizing and planning our working. Some data from staff grade doctors, similar levels of fatigue, similar levels of, well, slightly fewer admitted to driving when fatigued, and fewer had reported an accident, but still high levels. But perhaps this is because they work a little bit more and they live closer to where they work, so they're not like trainees who rotate round, and they have better rest facilities, I think, because they have a choice about where they work. And why would you choose to be permanently employed and work night shifts where you don't get to rest? I've talked a lot about anaesthetists, so I thought I'd pull out a few key bits of data from other healthcare professions as well. And this is a survey from the Royal College of Nursing from 2017 with over 30,000 responses, where nurses were asked about their most recent shift. So about half of them were doing long shifts, and this is from all types of nursing, actually, from community nursing, hospital nursing. And 60% said they didn't get to take sufficient breaks on their last shift. So I expect, with what we know about staffing levels, this is no better now than it was 5 years ago. And again, 46% said they were exhausted. Another couple of surveys from different hospital groups. So on our joint fatigue working group, we have representation from the Critical Care and Flight Forum from the Royal College of Nursing, and they've done a similar survey using some of the similar questions that we asked. Again, high levels of accidents and near misses, and actually they started to acknowledge the impact on patient safety, which we hadn't been brave enough to ask in our anaesthetic surveys. But you can see that 40% had recognised the impact that fatigue has on patient safety. Again, impacting on personal health and well-being. And EMTAs, the Emergency Medicines Trainee Association. So these are the group who were at the highest risk of burnout on Mike's slide. Again, reporting they were too tired to drive, same level of accidents and near misses, and 90% feeling that fatigue had impacted their performance. I mean, that's not surprising, that's very honest, but we know from what Mike said that fatigue will impact on our performance. So just briefly in summary, and then I've got a couple of slides on what we've been doing about this, which Nancy will then follow on to talk about. So I think we're tired and fatigued because we don't have enough core sleep quantity or quality, because we're humans like everybody else. But I think healthcare staff are particularly at risk because of their shift patterns and their shift lengths, and the fact that we work in an environment where we really regularly do not get access to breaks. But I think there's also this element of workload, the staffing shortages, and this idea that, you know, we have this chronic excessive workload which is leading to burnout that impacts on us. So what progress have we made? This is not my hospital, the image there. I don't hesitate to say. Although I do sometimes see very tired members of staff with their head on their kind of on the kind of desk in the middle of the night when I come in. But we do have better facilities than that. In fact, this is what we have. So just before COVID, this is my daughter several years ago now, we bought some sofa beds, which we've put in offices, because my hospital doesn't have any purpose-built rest facilities. Hospitals don't seem to be built with facilities for staff to rest in. But we do have lots of offices, and I think this is the challenge. People are not in their offices in the middle of the night, so why can't we have sofa beds in the offices and actually make spaces for staff to rest? So we started to do that, and we got another one of those beds during COVID, but I have 12 junior doctors on overnight, so 2 sofa beds is not really enough. The Fight Fatigue campaign, I think we were trying to start some fatigue risk management, although we didn't really know very much about it when we launched it. It was 5 years ago today. So the aim was to change the culture around fatigue in individuals and organisations. So we wanted to raise awareness of the issue, and I think we've had some success in that. So it's about detecting fatigue, being comfortable to discuss it and recognising it in ourselves and in our colleagues. We've launched an education package around fatigue and its risks, and we've promoted that amongst our specialty, and Nancy's got some resource packs with some information about fatigue and its risks. And then it's about obviously preventing fatigue where possible, so we've set standards for rest facilities and rest culture. But the challenge is, of course, turning those standards into practice. So you can say what should be done, but actually the reality of what is being done doesn't always translate. We've had questions in the GMC National Training Survey for anaesthetists only to try and track some of this work. So we asked people if they've received education on fatigue or sleep during this placement, and I've got the data up until 2021, but I was looking up the data for last year actually on my way here, and it's unfortunately dropped back down again. I think there was a kind of initial kind of enthusiasm for this, which was amplified during the pandemic, and then it's kind of dropping off again. So I think we're back almost to pre-pandemic kind of percentages now. Again, same as Mike, about 3/4 find it useful. We saw a drop in the numbers of people who had felt too tired to get home safely, but again, that's kind of plateauing off again now from last year's data. And we saw an improvement in the support to take rest breaks, but again, we're seeing a plateau in that in the most recent data. And then we asked about fatigue and how it had impact on people's progress through training. There we go. And again, that's gone back up slightly. So I think we made some progress with the launch of the campaign and raising awareness, and things got better when staff wellbeing in with COVID, but actually we've seen a lot of staff leave, and the kind of staff shortages and the kind of stresses on the system actually mean that we're sort of plateauing in our work. And I think the next step really is to try and think about how we've done our best to inform individuals about what they can do. We've described the problem, but now we need to think about the wider systemic changes that we can make to try to kind of improve the culture around fatigue further. So that's my discussion of the data, and my talk flows in nicely with what Nancy's going to say, but I'm happy to take any questions now. Thanks.
Thank you very much. Just touching on those resources, you can find those, can't you, on the Association of...
On the Association of Anaesthetists website.
Yeah.
I think there's a link to it in the
pack.
In the pack. Yeah.
Yes, brilliant. Thank you. Yep, we've got time for 2 questions.
Yeah, lovely. Thank you very much. So we'll go online first this time. So, Rich, do we have any questions from our chat?
Well, a couple of people mentioned, would we dare to put fatigue on the risk register? Or some people have said that they do in their local trust, but I wondered whether you had any thoughts on that.
Yes, I think that is I think that's the key, actually, using the systems in place we have at the moment to highlight this issue. And Nancy has worked for several years, and I think has finally got fatigue on her risk register. I don't think we've got that, but yes, I think that's a good tool.
Lovely, thank you. Do we have any questions in the room? So again, if you could introduce yourself, please.
Hi, thanks for the great presentation. My name's Tracy Hurley. I work at NHS England. I'm sorry if you mentioned this, but a lot of the survey data, is this from staff that are currently working? Because I'm guessing, has there been any surveys of staff that have left? Because I was just wondering, maybe the people who continue, kind of stick around for reasons that, fatigue or whatever, but maybe the staff that have left, you may find more so evidence of fatigue there, potentially, I don't know.
I think we probably would, wouldn't we? The difficulty is getting hold of the people that you have left. So yes, these are the survey data. The trainee survey was a 60% response rate. The consultant survey was about a 50% response rate. So we've got several, probably totaling over 6,000 responses there. But yes, we don't know. But I think it's fairly bad, the data we've presented. So, if it's worse in that group that have left, then you can understand why people would leave.
Thank you very much. We've got time for just one more question in the room here.
Thank you, Emma. Bill Kilwington, College of Operating Department Practitioners. You talked about the guidelines for 11 hours rest. Now, accepting the regulations don't apply to doctors in training, they are regulations, the 11 hours of uninterrupted rest. And in the NHS, we do not pay enough attention to the working time regulations. Now, whilst we've still got them, I think we should be making much more use of those.
Yes, and that's right. And so junior doctors with the new contract, they had the system of exception reporting when they didn't get their breaks. And I think, I don't know the data for how much that is used, but I suspect it's not used as much as it should be. So yes, as Mike mentioned, there was progress with the junior doctors contract, and there's some better kind of guidance, contractual obligations actually on rest regulations, but we don't track well enough when those rest periods are not achieved. Agreed.
Thank you very much, Emma. So we're just going to move on to our next speaker now, Nancy.
So I thought it was interesting how you pulled out the different reasons for fatigue between job roles, which is another thing that we're going to come on to a little bit, I think, because it's unique and it's specific to different job roles. But I'm going to hand over to Nancy Redfern, if I could just introduce you, Nancy. So Nancy's also a consultant anaesthetist at Newcastle. She shares the co-chair of the joint working group of fatigue with Emma. She was an honourable membership secretary at the Association of Anaesthetists, and that the similar reasons for your passion around fatigue is because of the death of the colleague in previous years. She advises on the European Patient Safety Foundation, is a member of the European Board of Anaesthesia, and you've done a lot of research which is very practical and pragmatically based. Isn't it? So thank you, Nancy.
Right, well, thank you very much for inviting me. So mine is a practical thing about, and I just talk about what I know, which is working in hospitals. I'm going to start by looking at Miller's Triangle, because I think a lot of us who work in education will be very much aware of this as a sort of core thing about how new things are introduced. So if we think perhaps 15, 20 years ago about coronary stenting for people who've got angina, you start off by thinking, knowing what it is and how it works. Then you've got to kind of think, well, how are we going to use that? Then you move on to can do. Is it feasible? Is it realistic? What are the practicalities of introducing that? And now where it is just part of the culture and the manner in which people who have coronary heart disease are treated. So if we use that as our framework, as our model, what we need to do is to think about how we use that within a hospital, within a healthcare setting. So first of all, well, what do we know about fatigue? What does the literature tell us? And of course, as Mike and Emma have alluded to, and as you will hear after the break, every other safety critical industry has fatigue risk management systems as a mandatory part of their culture. Nuclear, petrochemical, airline, lots everywhere, rail, I think we've got here. You look everywhere else. So what's happened in health? How have we missed out on this? I mean, I've got a theory, but I feel it's too important an audience to just test out Redfern's theories. So, okay then. So we can find out what we know, and we can find out how that has been introduced. And what have we tried in the NHS? So again, people have talked about rotas. Somebody's asked a question about 11 hours mandatory breaks. And Allocate, which is a nursing-based rota that I think is highly used, and Rotamap, which certainly we use in my own hospital for the doctors, both have a system of either you can't put that person on call again if they haven't had enough sleep, or a red flag comes up. So that you can monitor this sort of thing. Education. Mike talked a lot about the importance of people understanding why they need to sleep and the impact of not having enough sleep on their functioning as a clinical practitioner. But there's no point in giving people information about taking breaks and rest facilities if there are none of those roll-out sofa beds that Emma's been talking about. And lastly, one of the things I do is quite a bit of this sort of national, speaking at big things or running workshops. And I became increasingly aware that, one of the things you have to do if you do this sort of thing is to be congruent and realistic. And we didn't have fatigue on the risk register in the hospital in Newcastle where I work. So we have actually now, thank you very much to Tim White and Henrietta Dawson, got fatigue on our risk register. And so I will just talk for a couple of minutes about the story of what that's like as we just take the steps. Then the third thing is when you move from can do, so that people can see that there is a way of doing it, embedding into does that this is a behaviour that is just normal and nobody thinks about. There's a lot of that sort of biopsychosocial model of thinking and putting thought into practice that has to go on. So what does make people change? Well, you've got to recognise the problem. But there are 101 problems going along in the back of our head. And as Emma has said, actually our sense of urgency in anaesthesia came when Ronnie Patel died driving home from the Norfolk and Norwich to Cambridge. And it was just such a tragedy. He was going home, his wife was 7.5 months pregnant. She was a widow when she gave birth. That child never met Dad. Now, when I do talks, when I talk to people who do a lot of yes-butting, actually nobody thinks it's all right for Ronnie to have died. So we can go back to, this isn't good enough, we must make a change. And of course, as soon as people get that sense of urgency, they start to look for solutions. And those can be individual, but it's just so much better if you've got support from the organisation as well. So what do we do in terms of teaching on what do we know about the costs of, and I'm talking about that sort of chronic sleep deprivation, but also of sleep, when you just don't get any sleep. So after about 12 hours, our empathy is wearing a bit thin, and I certainly see that in when you're on call at night, the working relationship between the consultant surgeon and the anaesthetist could be a bit grumpy. Then we lose our intellectual flexibility that you really do need if you're dealing with a fast-changing emergency situation. So that, Emma describing, working on the labour ward. Logical reasoning becomes harder. Somebody anaesthetising a 3-kilogram neonate, and we tend to do the sort of calculations on our scrubs, and you can see that they've done a long calculation. They still can't work out what dose to give somebody. Vigilance becomes more variable. So that we do a lot of watching monitors, and we've had a situation just recently in the coronary care unit where I think somebody's just been a bit tired and not quite noticed something, and that's had some unfortunate consequences. Our ability to learn and retain information, and you've got to know which Mrs. Brown it is that's got the haemoglobin of 8. Our psychomotor skills, so we do epidurals, and one of the downsides of them is if you get in too deep, you can cause somebody a very bad headache afterwards. So the inadvertent dural puncture is what that's called, rates between 7 in the morning and 3 in the morning is about 0.8%, and then it goes up to 3%, and that's just because of our psychomotor skills deficit. Our mood gets worse, so of course our teamwork gets worse. So really, everything that has to do with patient care just gets worse. But as Mike has alluded to, we also have some damage to ourselves as human beings. As well as being more accident prone, diabetes, hypertension, strokes, heart attacks, some sorts of cancer, particularly breast, prostate and bowel, but there's more data coming on about others. Depression and burnout, peptic ulceration I've put, but actually the top 10 most common diseases are all more common in night shift workers, so we're damaging ourselves as well. So what can we do about it? Well, one of the things we discovered from the airline industry is that something called a power nap will prevent we think people die driving home because they just have that bit where their eyes shut for a few seconds and then they just aren't concentrating, and there's descriptions of people driving across the central reservation, rolling their cars. And that it's shown in the airline industry that a short 20-minute nap, but you need 15 minutes to fall asleep, particularly if you take it in the early part of the night, actually is quite effective at stopping those sort of micro-sleeps. They talk about having a caffeinated nap. So you have a cup of coffee before you go to sleep, and then they say that the caffeine, which is an adenosine blocker, and adenosine is one of those somnogens that makes you feel more and more sleepy, that will take effect. I'm not quite sure at a certain age if it's not your bladder that wakes you up, but there you go. And this is a study done by somebody called Professor Geiger Brown, which she did in Wisconsin. And she got two groups, both of 6 different teams of nurses. And one group were asked, the top lot, were asked to carry on normally. And this is a graph the same as you've seen from Mike. And you can see as they carried on normally that their weight propensity, their alertness level went down and down and down. The lower group, which is another 6 different teams, you can see where they've drawn the circle, they were given a 30-minute power nap. And they were more empathic, they felt safer driving home, and I think that they had fewer drug errors. But the problem she had was recruiting that set of 6 teams in the bottom half. The senior management thought it was unprofessional to sleep while you were on duty, even though it's safer for patients and safer for themselves. So in the end, the American Academy of Nursing changed their guidelines to encourage power naps. So what's our experience in Newcastle? Well, to try and explain to people and see if we can introduce power naps, to think about discussing tiredness at ward rounds, when you have an evening ward round, well, who's going to have which nap when, who's already tired. Lots of our midwives coming to work when they're already tired because, their childcare's broken down, perhaps. We found that some people wanted, they moved from the midwives drawing up the rota for each other to self-rostering because people knew their own physiology. They knew they couldn't stand more than 2 nights, working 2 nights. Changing what we do. 1 a.m. and 7 a.m. for 6-hourly medicines. 7 a.m. is much safer than 6 a.m. because it's outside that circadian nadir. Minimising that sort of routine work. Do not try and restock the orthopaedic theatre at 4 in the morning because it looks just like the paediatric theatre on the floor below, and you'll suddenly find that it's got all the ENT stuff in it and none of the orthopaedic stuff. Well, that's a nuisance during the day. So double checking when you're doing something at 4:30 in the morning, just really check, is this right? Am I giving the right dose? And the new thing, I think, for us is very much about involving patients. So the other bit is about information, and this is our sofa that turns into a bed, the arms go sideways, and so that gets some rest facilities. I've brought with me some of this, which is our Fight Fatigue campaign. We've got all these infographics and things, and there's a QR code if you want that there. So what we've done in Newcastle is we've hung them up. This is them on the loo doors and on the back of the in the changing rooms. Then we found half the people weren't reading them, so we had to send somebody into the gents, something to do with the height they were put at. So we've got these. We've got information, education, and we've got some rest facilities. One of the other brilliant things that happened was that the Royal College of Anaesthetists set some standards. There are three sets. One's about the organisational culture, one's about individual behaviour, and this one's about rest facilities. And that's given us something that we can audit to see how we're getting on. But the other thing is to actually introduce a fatigue risk management strategy. And those have a predictive element, a proactive element, and a reactive element. This comes from Drew Dawson's editorial. Of course, everybody said, well, we can't do this because we'll need more staff. Actually, I was told that by the clinical director. We can't introduce fatigue risk management because we haven't got the resources to do it. But actually, you can do it with what you've got to some level. If you look at the frequency, the duration, the intensity of work, having somebody senior on every shift who can take that mental strain off the less experienced people, and that supportive culture makes a big difference. We got this Fitbit that turns into an app that you connect to a Fitbit, which actually comes from, I think, the road haulage. And what it shows is a prediction for your next 20 hours of how sleepy you are. And in the red, you'd be more than 5 times more likely to crash your lorry. Well, I've seen an obstetrician hold it up and say, well, I'm in the red, somebody else do this section. Very sensible. And this is a comment from a midwife who realised she wasn't getting enough sleep between night shifts and really worked on let's get 8 hours somehow or another. So looking at workplace activity, looking at rest, making sure we've got rest facilities. We bought ours using the money Sir Tom Bourne raised walking around his garden. That supportive workplace culture so that we can make night shift working as good as possible. So we've got a lot of potential actions and we've got information and facilities. But what is really needed is that change in organisational culture. And that's where, having kind of gone around the houses for years and years and years, we have finally got to a point where we've got a bit of data collection from our DATIC system, we've got some reporting systems, we've got some more expectation that people might have a rest. Sanctions we're not very big on. I think this is about praise and not punishment. So the thing we found that has been the most useful to change the culture is to engage people. Each team, each department has a different culture and has different things that will mitigate their risk. So describe what goes wrong and help them think what good ideas are there from the airline or the rail industry. Tom Lehrer said plagiarise, let no one's work evade your eyes, and that's what we do. Empower and support them and get them to network so that this just becomes part of what we do. We had a bit of rewards because we went to the House of Commons on Monday, so that was quite good fun. So eventually, by doing all of that, we hope that if we can address the risk at a systematic level, recognising it, developing the sense of urgency by talking about it, measuring it with audit tools, and we do have one if you want, with stories to suggest remedies, academic evidence, to involve the team so that they design their own system, and to reward success, and then to keep going with all these surveys, the GMC, CQC, and I hope HSIB. So that's me. Thank you very much.
Thank you very much, Nancy. That's brilliant, and some practical takeaways there, I think, for everyone. We've got time for questions.
Yeah, thank you very much. Just before we do that, a few people online are asking for the QR code to be put back on the screen because they missed it. So if we could go back to that slide, that would be great. Fantastic, thank you. So do we have any questions in the room?
Hello, I'm Helen Hughes, Chief Exec of Patient Safety Learning, a charity. Fantastic presentations. Wondering what's happening outside of hospitals, particularly in terms of primary care or community services, because that's less visible. Just wondering what work there.
Way above my pay grade. I'm a jobbing anaesthetist. But we do know about ambulances, so Christie's your man for that.
So yeah, we will be covering that at the end. We're going to end on a high with Christy, sort of moving into work is big, ongoing, and hopefully will become an exemplar perhaps in other fields. So yeah. Have we got one from
Thank you very much. So if I can go over to Rich online.
Well, first off, there's lots of interest online in the idea of nap schedules and power napping, and then a bit of a discussion about who does and doesn't get to sleep and whether it's forbidden or whether they're paid and not paid. But there are also a couple of comments from people about people who've transferred over from other domains such as aviation, where, for example, the RAF getting pilots to fill in fatigue surveys and potentially stopping them from working even if they don't feel tired. And also somebody else talking about using wearables to measure fatigue. And I didn't know whether you had any thoughts on how ideas like that could be sort of implemented within healthcare or whether they should.
I mean, we had a go with the wearables, and they were jolly useful as a sort of experimental tool within a research project. But I think one of the challenges I feel about them is that that's going back to what Mike's saying about resilience. It's about putting the onus on the individual, and actually what we need is the department to collect the data. And what we showed was that nurses and midwives had an hour less sleep than doctors. Now, those are the data we need to be picking up. To me, resilience is the outcome of an effective team. It's not a personal thing. So it's a good idea. It will show you what you've got, but use with caution. Is it copyright?
Thank you so much, Nancy. So next we're going to turn to listen and hear about how other industries have experienced and looked at the field of fatigue. So I'm very excited to invite two of our speakers up together. They're going to do a double act for us from the marine and the rail industry. And if I could introduce, first of all, Mark Young, who's an inspector. Okay, I'll introduce Will Tutton first. Who's an inspector in the Marine Accident Investigation Branch and has worked in defence previously for over 20 years. He's a Chartered Fellow of the Chartered Institute of Ergonomics and Human Factors, and he's got a very long history and looking at fatigue in the marine industry. So if I can invite Will up, please. Thank you.
Thanks, Laura, and thank you again for the opportunity to speak to you today. So Mark and I are going to be talking about two different industries, and hopefully you'll see some parallels, obviously see some differences, but also we'll speak to a lot of the kind of issues that previous speakers have talked through as well. So why is fatigue relevant to us in marine? Well, it's generally a common contributing factor in all transport modes, and unfortunately including fatalities. We see a lot of this, certainly in marine. All transport modes have have evidence of severe sleepiness or sleep onset, and you've seen a lot of the sort of research already on some of the sort of biophysical mechanisms and so forth. Is it the strongest performance performance shaping factor in maritime accident? I think the evidence is a bit mixed, but certainly it is definitely up there. I would say it's prevalent in pretty much all subsectors of the maritime industry. We're an industry that's incredibly diverse in operation. We've got everything from cruise ships through to single-handed fishing vessels, and arguably endemic, and that's not just within the UK, that's globally. Shipping is a global industry, and so when we talk about it in the UK, we have to set it within that international context. I would also say, and I'll come on to talk a bit more about this, is actually how do you then manage that? Because the standards of practice vary hugely. You come from a very, very evidence-based profession. Shipping is a highly commercially based operation. and some of the drivers for how you can address fatigue really have to fit within that context. I'm not going to talk any more about the sort of particulars of the biophysical mechanisms. You've already had a lot of that already. Just to sort of touch on some of the sort of issues that we see, these are some of the common aspects that we see in terms of contribution and causality in accidents. So you've got aspects of communication, poor emotional team performance, memory and sensory processing affected. Reaction times can be really reduced and impact in terms of emergency response. And decision making is a huge aspect of, for example, collision avoidance and so forth. And some academic research indicates that that can be, as high as 85% of the accidents that we see in that regard. And I don't emphasise, while that may result in low levels of fatality, the actual economic cost of that is absolutely huge. I mean, if you're familiar with the Ever Given grounding in the last couple of years, that's resulted in millions and millions of dollars worth of economic hardship, mostly to companies, I'm pleased to say, rather than to the taxpayer. Task performance is negatively affected, and we've heard some information there about sort of how it affects different people differently. We certainly see a lot of that in maritime. And more and more worryingly, in terms of crew performance, ships' crews can be on board for months at a time, and that socio-interaction can be really, really damaging, resulting in suicide, resulting in attempted murder, and other sort of really, really poor outcomes in terms of social interaction. Less alone the chronic ill health effects. I work in a team of 13 investigators. 3 or 4 of them have chronic long-term health effects from being at sea. So some of the maritime considerations, mentioned already, it's a global industry. As an aspect of sort of social sacrifice in terms of being away from friends and family for long periods of time. Seafarers face extreme health hazards. It can be boring and monotonous work. They've got few basic rights during the pandemic. Health workers were regarded as key workers, but the seafarers bringing food around the world, they were not regarded as key workers, and so we saw a massive increase in imprisonment of sailors who were just trying to get home after their stints on board. High risk of mental illness and living in what can only be described as fairly Dickensian environments on some vessels. With potentially punishing work patterns. I mean, we've heard debate here about sort of 8-hour shifts versus 12-hour shifts. Some of the seafarers that we deal with are working 6 on, 6 off, sometimes for months at a time. Incredibly, incredibly damaging to their health, let alone their performance. As one of my sort of colleagues put it, and this is just a paraphrase, tired sailors are not heroes. Being tired is part of being a sailor regardless of rank, trade or nationality. They are a danger to the ship. And unfortunately, that can be pushed onto them by the operation and the limited resources that they have. So in that regard, ships are probably in a worse state, I would argue, than some of the situations in the health service. Now, people have different motivations for working on board. Often there's a monetary sort of reward for it, and there's other kinds of sort of interpersonal aspects as well. But they are very much victims of a systemic sort of management failure from that perspective. In terms of regulation, I think we've heard reference to in the UK Working Time Directive. And there's been challenges and discussions of that. I come from a medical family. It's something we discuss quite a lot over the dinner table. Interesting conversations, I have to say. And internationally, and the UK particularly, we have MSN 1877, which limits seafarer times. But all we really call for is 77 hours as a minimum in any 7-day period and 10 hours of rest. Okay, so that's well below what we see in the terms of the Working Time Directive. Also, there's little guidance on fatigue risk management systems. So it was interesting, earlier we heard a reference, is it safe to implement fatigue risk management systems? And in shipping, in some sectors, absolutely, it is not safe to even start to go there. But other parts of the trade, yes, absolutely, and there's no reason why they shouldn't be going there. So just to sort of give you a couple of sort of indicators there, these are probably what you'd regard as the sort of top end of the fishing industry. So you've got cruise ships, large containerised vessels, specialist bulk hauling vessels on the left there, all the way through to smaller vessels such as this BBC vessel, so general bulk cargo. These are typically where we see the 6-on, 6-off trade, usually 2 deck officers managing the whole ship, usually with about somewhere between 5 to 7 crew. There is no way they have time to do all of the jobs that they need to do, particularly when in port. Vessel I dealt with recently, they were actually impounded by the regulator because they were boarding a pilot to take them into port during their alleged hours of rest, and the regulator had no sort of conception that they didn't have the time to do it. So regulation does not reflect best practice on board, and that is hard baked into some of even UK legislation. So it's a really difficult environment to operate in. And there's just a few other sort of examples as well. All the way down to the vessel at the bottom there, really interesting ships. They're pelagic trawlers, a bit like the Starship Enterprise there. Everybody imagines fishing to be rusty old bulks and sort of pulling up the fish, in the middle of the North Atlantic. These guys see the fish twice. Once in the net at the back of the ship, once as they come over the hoppers into the hold. That's it. They are like, it's like a hotel. They're fantastic. Their hours of work and rest are really quite good, actually. I was really quite impressed when I saw those. All the way through to these little things, and usually when we go to a fishing accident, I expect them to be fatigued. End of story. We look for it every single time, and usually we can find it. So what's the reality? And I think you already sort of can tell where I'm going with this. So we first got involved with this sort of area back in 2004 with our bridge watchkeeping study. This is very much focused on the lives of deck officers who are navigating the vessel, and we have quite a few examples at the top there. I think that's Jambo, sort of managed to, the first officer managed to drive it up Hebridean Island, falling asleep in the middle of the afternoon. This really looked at all collisions between 1994 and 2003. It's probably about time we revisited this, but we really concluded from that the levels of safe manning, as the international legislation provides it, are not effective in managing this risk. And I think that the sort of calls you've had here to put this on the hazard register of your trusts and your organisations is absolutely the first step in beginning to manage this. We then, shipping legislation is done globally. It's done through the UN body, International Maritime Organization, and we put a recommendation through the UK to ensure that there were more resources available on the bridge, so a mandatory 3 bridge officers to manage 24-hour operations. Member states refused to do this change, but did concede you should have a lookout on board. And even now we find vessels that don't do that, even though it is the best practice and it is legislatively required. The need for us to redo it has really been overtaken to a degree by this, by the World Maritime University study in 2020 on this subject, and that's now been taken back up to the IMO to begin to address some of these issues. And this has begun to talk about, routine, what we call flogging the log. So basically, those hours of work and rest records, we know those are habitual. Artifacts. They're not real. They don't represent real work. So we actually have elements of criminality in terms of people actually not recording hours of work and rest, because there is an expedient for people to do that. That's not their fault necessarily, but that can be a part of it as well. So a couple of case studies before I hand over to Mark to talk about some of the better practice that exists in rail. Again, all of these sectors are in change, and we have to look at it in the context of constant improvement. Louisa, very sad case. This vessel had been operating for 4 days, working 20 hours a day. The crew awoke suddenly and find the vessel sinking rapidly by the bow. This is up in the Northwest Highlands, and you can imagine extremely cold water, very isolated environment. They got out literally in their t-shirts and underpants, released their EPIRB, but couldn't inflate their life raft. Managed to get their life jackets on, although some of those were actually defective as well. 3 of the crew perished, and we know that from their hours of work, fatigue was a massive part of this. The ultimate cause, we think, again, some of this is very difficult to prove. The main engine was running with the engine engaged astern with the Vivia system. This is a fish cooling system pump going. All the hatches were open, and we think the deck wash pump was still going and probably fed into the hold, which made the vessel sink. So you see a number of different sort of elements there, all related to fatigue in terms of decision making and their alertness and being able to plan accordingly. Really, really sad event. Another good example, we see a lot of these kind of things generally, and that's vessels going around during a period of circadian low. A lot of our accidents happen during that period, and this is just a good example of that. Officers of the watch didn't monitor the ship's position. Again, the introduction of things like mobile phones on the bridge, very monotonous job. So, you know, looking at the phone just to sort of keep themselves awake. And I'll leave you to read that. But lots of sort of, you know, elements there in terms of roster pattern, the actual task environment the person was in. From memory, I think this also actually did have 3 crew on board. So just having more crew doesn't necessarily get you out of free and to address these issues. So at that point, that gives you a bit of highlight in the shipping industry, and I'll hand over to Mark to talk about the rail industry.
Thank you, Will. So yeah, if I can introduce Mark Young, who's an inspector of the Rail Accident Investigation Branch. He joined in 2022, previously worked in academia and has done a lot of work in this area as well. He's got 25 years experience working in human factors and holds a degree in psychology, PhD in human factors, and is a fellow of the Chartered Institute and visiting professor at the Loughborough University. Thank you, Mark.
Thanks, Laura, and thanks also for the invitation to come along and opportunity to talk today. Try not to think about the 1,000 people watching online. That's kind of distracting. But so the rail industry, of course, is another 24/7 safety critical industry. Shift work is, of course, part and parcel of what we do. And as we've heard already, where there is shift work, there is the risk of fatigue. So it's an issue the industry has been dealing with and will continue to grapple with as we go forward. And it was really brought into sharp relief, I think, for the industry in 1988 with the Clapham Junction disaster. I'm sure many of you will be familiar with when a signalling failure, a wrong side signalling failure, so a signal that should have been at red to protect a train that was stationary in the section ahead, but the signal was actually at green, so a train running from Poole to Waterloo crashed into the back of a train from Basingstoke to Waterloo. 35 people lost their lives. Massive impact on the industry. And the inquiry led by Anthony Hidden QC found that amongst a number of issues, that was the actions of a signalling technician working the night that led to the failure of the signal concerned. And amongst the influences, and many systemic issues, of course, with the disaster, but of course fatigue played a role in it upon the part of that signalling technician. And the inquiry found actually that it was quite common that many of these signalling technicians were working excessive hours. In fact, there was a significant proportion of them working 7 days straight for 13 weeks prior to the accident. So the inquiry report resulted in a number of recommendations, amongst which were what have since become known as the hidden limits, so limits on working time for this kind of safety critical work. You can see them on the slide there. Now, these were what was seen as operationally achievable at the time. They are quite, as you can probably tell, still very quite punishing. You know, you can roster up to these limits and still be very, very fatigued. But at the time, it was kind of like, you know, reining the industry in a little bit. Since then, the industry's moved on and is trying to become more mature in terms of fatigue risk management systems. It was laid down in legislation in the Railways and Other Guided Transportation Systems Regulations 2006, and Regulation 25, as you can see on the slide there, sets out that safety critical workers, to paraphrase, should not be fatigued such that their health and safety could be significantly affected. And it sets out a 9-step approach to doing that, which is effectively good practice in fatigue risk management. I'm not going to go through that in detail right now. I'm going to talk a bit more about fatigue risk management practice in a second. But that's what's laid down in legislation, trying to take us a little bit beyond those pure sort of working time limits into a more sort of qualitative culture of fatigue risk management. And in 2012, both the regulator, the Office of Rail and Road, and the RSSB, who set the standards for the industry, conduct research on behalf of the industry, they both published quite detailed, very useful guidance on fatigue risk management, which is still available today. It's 50 sort of 60-page documents, a lot of really good stuff in there. And as I say, that's really trying to push the industry forward into thinking about the wider aspects of fatigue risk management, which includes, as I say, not just working time limits, but a whole bunch of other stuff. Of course, rostering is still a part of it. Of course, it's the primary tool that organisations have for managing the work-rest schedules of their employees, but it talks about fatigue reporting, fatigue monitoring, so trying to get those reports from frontline workers, not just about designing the shifts around good practice, but understanding which of those shifts feel fatiguing to those workers. And it might look good on paper, but if people are saying no, that's still punishing for whatever reason, then taking that back on board, investigating fatigue and incidents and doing that in the right way. Education and training as well. I think we've heard a little bit about that already today. So actually, not just for frontline workers, but also for the management, understanding what shifts, what types of duties impact on the workers, and trying to take that into account when planning work and rostering and work rest schedules. It's a bit difficult, that sort of stuff. It can start to come across as a little bit paternalistic. You're telling me how to run my life, you're telling me when to go to bed, that kind of thing. But it's all about sort of engagement, educating the workforce and putting the responsibility both on the employee as well as the employer to manage that. And that's all bound up in the sort of culture of the organisation as well. And this is, I guess, where we've still got a lot of work to do in the industry. I think at sort of higher levels, you'll find your organisational policies, that kind of stuff. It is, again, sets out good stuff on paper. They're trying to move in the right direction, but there's a lot of people out there, particularly sort of frontline workers still in the rail industry, that come from the older ways of doing it, and people still sort of feel that there are ways of doing it in the past that again, the resilience sort of issues, not supposed to nap on duty, that kind of thing. I'm going to skim over this. The regulator puts out, as well as that detailed guidance, there's like a 2-pager which sets out good practice in rostering guidance. And it is guidance, but this is, in terms of work rest schedules, and it's risk-based as well. So you can see some things in there, for instance, night shifts and very early shifts should be shorter than day shifts, because the risk of working at night and on very early is greater than working in the day. So there's lots of good guidance out there. I want to illustrate some of these issues just with briefly with a case study that I worked on myself a few years ago. It's not the most spectacular, this one. There were no great consequence in terms of harm or damage. These were effectively 2 freight trains that ran past signals at dangerous, ran past red signals on the Great Western Line near Reading. The reason we got involved, because there were 2 very similar incidents, both fatigue related, both within months of each other, and both within a few miles of each other either side of Reading on the Great Western. They involve the same train service. It's a freight train, so it runs up from Merehead Quarry up to Acton in the early part of the night, stays at Acton while they unload. The driver has some downtime at Acton Yard, and then they run back with the empties in the early hours of the morning. And on both of these occasions, these drivers went past these signals at danger because they'd had a momentary sleep event. There's lots of issues that came out of this investigation, which is to say why I wanted to highlight it. One of which was the amount of sleep that the drivers had had. So both had only been working on about sort of 3-4 hours sleep over the period before that, for different reasons. One of them had some ill health in the time leading up to the incident, so they were short on sleep because of medical issues. The other driver, it turned out during the investigation, they had some sleep assessments, and they had an undiagnosed sleep apnea, basically a very severe case of sleep apnea, which they didn't know before the incident, but that turned out as part of the investigation. But a whole ton of other stuff came out as part of this as well. So I mentioned that downtime they have at Acton Yard. Both drivers wanted to have a rest there. I wanted to have a nap, basically, catch up on some sleep. But the rest facilities at Acton were not the greatest for napping, let's say the least. So it's this porter cabin in the middle of a yard, you know, it's got blinds falling off the wall, a shabby sofa that's not very comfortable sleeping on. The so-called quiet room was between the TV room and the kitchen, so it was kind of on a thoroughfare, so it wasn't the best, it wasn't most conducive for having that nap. So although both wanted to have a nap, they weren't able to actually get that rest during that. They were both working long night shifts, so I mentioned before about the risk of working long, and I said they'd be sort of 10, 11-hour night shifts. They'd come on sort of 11 o'clock midnight the night before and working through to the early hours the next morning, and these incidents happened at the sort of tail end of that window of circadian low as well. Neither driver reported fatigue, and this was another interesting factor. So one driver didn't report for what I might sort of call positive pressure reasons. They thought if they binned their job and they would drop somebody else in it, basically. Somebody else would have to take on that duty. It puts pressure on the rest of the team, that kind of thing. Whereas the other driver didn't report for what I sort of think of as negative pressure. They thought it was not the done thing. They thought they'd get in trouble if they reported being fatigued. They thought, you know, that whole resilience thing again. They had to just crack on through. Lots of other organisational issues at both sort of local and sort of bigger sort of company management in terms of rostering, fatigue risk management, and the napping issue came out of that as well, as I say, in terms of the rest facilities. I haven't got time to go into great detail. That report's published online. You can look into great detail about that. These issues we bump into still. We've still got ongoing investigations, particularly with, again, sort of freight drivers, track workers who tend to work through the night as well. But just to close, I mean, what we've found in our investigations is that fatigue has come up as a main causal factor in about 20% of our investigations. That tallies with research by the RSSB. It's also paralleled in automotive as well. I think we'll say that it is a people issue. Everybody's susceptible to fatigue. It's a shift working issue. It's not just bespoke to rail. The napping issue, what we're sort of saying, what the message we're trying to get across in rail is that that's a mitigation, it's not a control. It's all right if you're caught short, it's okay to do that, but please don't rely on napping as a fatigue control in your fatigue risk management systems. And it really is about sleep. So the rosters, we keep trying to remind people, the rosters provide the opportunity for sleep. It's about people getting the right rest off duty and coming into work fit for duty and well rested. And that, of course, as I say, is bound up in the whole sort of cultural reporting issues as well. I'm slightly out of time, so I will stop there, but thank you very much indeed for your time.
Thanks, Mark. If I can invite Will back up again. Thank you so much. You will find on the resources that are put on our website some of the information that Mark's covered here, because I direct people that way, and also the Patient Safety Learning Hub. Again, there's some information there. Have we got some questions, Mark?
Yeah, thank you very much, Will and Mark. So we're going to go to our online community first. Rich?
Will and Mark, there's a couple of related issues that people have mentioned about both regulators and whether regulators such as the CQC should be routinely looking at fatigue, if this is something that we're acknowledging should be part of our risk frameworks. Should they be going and inspecting for that? People are saying the fact that we're possibly preaching to the converted. We can all agree in the room and out there that this is an important issue, but particularly you, Will, you were talking about the pushback you had from within the IMO when you tried to make change. So how can we make change? And then the third point is about criminality and organisations being prosecuted when they're failing to manage fatigue within their workforce, and whether you had any thoughts on that. So I'll hand over to you guys.
Okay, yep, so I can't really speak too much for what the regulator does, but the Office of Rail and Road has been pushing for better fatigue risk management in the rail industry for a number of years now. They try not to be too prescriptive, but all that guidance I put up and the fatigue factors, that all comes from the regulator. And actually, when we investigate as well, we assess the rosters and the fatigue risk management systems against the regulators' guidance. In terms of prosecutions, again, the regulator recently did prosecute a rail industry company actually for a road-related fatigue event where some contractors died as a result, a bit like the one case we were hearing earlier about some people driving off the road, and that company was fined a significant amount of money and successful prosecution by the ORR there. On your side?
Yeah, sure. I'd say, in terms of investigations, what you look for is sometimes what you get with this. We've got fairly clear evidence from our investigations that when we've looked for it, we find it a lot. When you don't, that drops off a lot. So having really good guidance for your investigators is absolutely key. In terms of the sort of realism from an enforcement point of view, in maritime it's really difficult because we're really governed by the international regulation. That said, the regulator has in the past issued some good general guidance, but it hasn't gone as far as ORR, for example, in terms of looking at fatigue risk management systems, but that is not required globally, unfortunately, in our sector. But I think you've had some really great examples earlier this morning of actually there could be more of that. You know, there's no reason why you have to do the legal minimums, which is what we find in the shipping industry. You can go way beyond that, you know, and address it as a risk-based hazard.
Thank you very much. Do we have any questions in the room?
Hi, my name's Hester. I work for NHS England. My pronouns are she and her. I'm going to ask you a slightly challenging question from an inequalities perspective. As a menopausal woman, sleep deprivation is something that is normal to me, which isn't much fun. But I'm just thinking that possibly the two industries that you are in are maybe less well populated by women, and I'm particularly reflecting into the NHS that we have around 75% of women in our workforce. So I'm posing that question around thinking of actually some of these inequalities will start impacting in different places, but also there's a huge taboo about the menopause. People don't talk about it. So actually, will you even find the answer to that question unless you pose the specific question? I'm not sure whether I'm expecting an answer or not, but I just thought I'd raise the issue. Thank you.
You go first.
Thanks, mate. No, really, yeah, interesting. I think that it can certainly be a big challenge. We're seeing in some parts of the industries that we have a lot more women come to the fore, a lot more female skippers, which is great. Unfortunately, the shipping isn't really there in terms of any of that sort of agenda changing things, unfortunately. Hopefully in the future they will be more accepting of it. And that's a really good note to us to improve our investigatory elements of that area. Thank you.
I'd second that. I mean, you've rightly guessed, rail is very male-dominated, I'm afraid to say. It is getting better, and I think particularly in the passenger side of things, but to be honest, a lot of what we get is more sort of freight and track work in terms of fatigue, and passengers, well, it doesn't tend to run so much in sort of unsociable hours. But yeah, again, I mean, we try to think of all sorts of lifestyle factors. It's a good tip. I mean, it's something I think we ought to think about going forward in our investigations. We do try to consider other lifestyle factors as well, that kind of thing, and that's another one that we should build into that. You're absolutely right.
Thank you very much. There were quite a few hands up in the room, so could we please make sure you capture your questions on those post-its so then we can hopefully get the answers after the event to share with everybody. Thank you very much.
Thanks a lot, guys. Thank you. Excellent. So we're going to end on a high now with Christy Sanson, who's going to speak to us about her research that she's been doing in the area of fatigue management systems with paramedics. So Kirsty is a chair in the Applied Health Research School of Health Sciences, the University of East Anglia Mental Health. She's the theme lead of the NIHR Applied Research Collaboration of East of England, and her background is in psychology, epidemiology and public health. But she's the chief investigator of the NIHR-funded catnip study, which she's going to talk to you about today and hopefully move us forward in healthcare. Thank you.
Great, thanks Laura. So my job is to bring us back to health, and I'll talk about kind of broadly health and social care with that, but using the ambulance sector as a case study. So hopefully this is going to do a job of bringing together some of the threads that we've heard through the questions. So what's happening out of hospitals, what's happening with menopause, how can we actually make change happen? These are kind of all the things that this project is touching on. It is a research project, so we're very lucky to have received quite a large grant to work through all of this for this particular sector. But I first want to give a shout out to my colleagues. So we've got a fantastic team of paramedics, fatigue and human factors experts. I want to particularly acknowledge our patient co-investigator. A really important part of this story is how we bring the public and patients and our communities with us in these conversations. And I'll also give a shout out to our paramedic co-investigator, John Rogers, who I'll talk about in a minute, who is a paramedic with lived experience of the direct consequences of what happens with fatigue on shift. And we've also had great input and representation across a number of ambulance trusts through various roles. But I'll start with some guiding principles. We've heard some really important questions about what really is feasible here, and should we even be trying to go down the path of replicating what's done in aviation, marine, rail. And we're taking a very, very pragmatic approach with this study. We know that more resources would help, and we have to keep pushing back on that. But there's a whole lot of other factors that are not due to staffing and rosters that we need to look at. We know that staff preference is really important here. They will continue to work potentially unsafe patterns or hours for legitimate or at least understandable reasons, whether it's financial, commitment to community. You might be the solo first responder in a remote area of Scotland, which is one of the people we've been talking to. They're not going to do an app or a fatigue tool and not go out if they get a call. Of course they're going to respond. So what can we do to keep them safe? And for me, it's really important to emphasise a harm minimisation approach. It really is the only feasible option in health and social care that can run alongside some of these kind of more longer term or political challenges. And always something is better than nothing. Smaller steps are better than no steps. And we've already heard this morning. For us in this project, we're very much looking through an equality and diversity lens. What works for one group of staff may not work for another. And so we need to be constantly asking ourselves the question, these are all kind of fabulous on paper and it's all sitting in the literature, but how do we make this real for this particular staff member? So I'll come back to our paramedic co-investigator, John Rogers. He has a very powerful and very personal story of what happens when things go wrong. He had a road traffic collision, driving an ambulance through a microsleep. Thankfully, John is still here to share with us and tell us about his experiences. This was treated as John's fault. He was taken through the courts, he had a fitness to practice. Thankfully, he had a highly supportive trust who was there every step of the way, and they were all dismissed. But this should not be taken as John's fault or an individual clinician's fault. This was a system fault, and so we have to keep that thinking constantly throughout what we're doing, which is precisely why this event today is so fantastic. So I call this building a coalition of the willing. We've already kind of talked a lot about why this is hard, why we'll get pushback. But I guess we wanted to kind of finish this session as a positive example of that you can get the political will to tackle this at the highest levels within a sector within the NHS. We spent probably about 18 months of groundwork getting everyone together to say, should we even go down this path? How do we do it? What sort of questions do we ask? Who do we need to talk to? And these are all the groups who were just fabulous in helping put us on the right path in terms of what should we be trying to do? What sort of questions should we be asking? And that was everything from kind of individual frontline staff, chief executives, health and safety executive, patient and public advisors, industry partners who are developing some incredible technologies and systems to help support fatigue risk management. So the study, just for those who may not be familiar, there are 13 standalone UK NHS ambulance trusts. So as a sector, they can work together and be flexible really well because there are only 13 of them covering the entirety of the UK. We've got 12 of these trusts working with us in this study, which is absolutely fantastic, including Wales, Scotland and Northern Ireland. So what are we doing? The questions are going to be no surprise for you. What is best practice? What can we learn from aviation, rail, marine that could possibly work in the NHS and in particular ambulance? And importantly for me, our eye is always on an immediate answer may be no, but why is that no? And what can we do about it? So I'll take you through kind of the steps and the questions we're asking to say, how do we take that immediate pushback and see if it's a real no, or is it a not yet, or not until we've got these things in place? So we're doing this through a kind of a range of approaches, but we're going to end with, I think, some really important observational work and some interviews with staff and patients to see we can do all these things, we can make all these recommendations, but how is this actually going to work in practice in their setting with their sort of facilities that they've got? And then the last piece, importantly, will be unpacking this for ambulance services to say, how do we actually affect that change? So that's where we're working with our implementation science colleagues to use some approaches to break down those barriers and say, how can we actually tackle this and make the appropriate change happen? Again, acknowledging this is not going to necessarily look like what's done in aviation or rail. It will look like what could be done in the ambulance service, and I think that's what's really important. It has to be tailored to the group that you're working with. So I was really pleased to hear some of the other reasons that somebody may have very significant sleep disruption, which can lead to fatigue or can directly lead to fatigue. So of course we know about the importance of shift patterns, shift breaks, work intensity, job stresses, inter-shift recovery, how you travel to and from base. But also, particularly in our health and social care workforces, we need to link our staff wellbeing agenda to this. We know that sleep disruption is very strongly associated with depression, post-traumatic stress disorder, anxiety disorders, chronic pain, menopause, long COVID, alcohol use disorder. We've got a whole range of things there that we absolutely must link into what we're doing for staff wellbeing, because there has been some incredible efforts through COVID and ongoing. We need to make this part of our fatigue management conversation because it's a really important part of how we tackle this problem. And of course we have to contextualise this to where people live, not just where they work. Who do they live with? What sort of personal, cultural, religious practices do they observe which may impact on their sleep at certain times during the year? And all the kind of basic what we call sleep hygiene that we can help staff deal with. So across our whole big evidence review that we did, looking at all the various industries and sectors, looking not just at kind of the published scientific evidence, but also organisational case studies, because a lot of this evidence does not sit in journal articles. It sits there out in practice, as we've heard from our colleagues this morning. And we've organised this into kind of two parts of action, the fatigue reduction, so kind of the primary prevention, and the fatigue proofing. So we know even if we did all of our preventative activities, we'll still have staff turning up who are fatigued. So what do we do on shift to try and keep them and their patients safe? So I'll go through the 20 strategies that we've come up with for discussion with the NHS ambulance sector. All of these we've pretty much heard before. A couple of kind of more kind of novel ones, sleep banking, should you kind of get some sleep in the bank before you go on to sort of a run of nights. Chronotype match rostering. There are some kind of interesting sort of early examples of how you design entire rotas around people's natural sleep biology. Are they a morning person, a very late night person, and what are the challenges around that? And of course, we've mentioned education. We've mentioned within the health and wellbeing, we should be looking at conditions that impact on sleep. And of course, we've got our senior management and management support thinking about fatigue policies and frameworks. In the ambulance sector, we know that there is only one of our 13 trusts that has a fatigue management policy. When we first started this, there were actually very little mention of sleep as an issue or sleep management in staff wellbeing policies. That's starting to change, which I think is really important. When we talk about minimising consequences on shift, again, we've heard about should we be looking at wearable technology, should we be looking at environmental fatigue detection technology, what sort of mitigation measures on shift should we be promoting? We've already had a bit of a chat at about napping, very controversial when we talk about this with colleagues. You'll see a quote about that in a minute. But should we be promoting kind of lighter interventions on shift? Talking to some kind of ambulance manufacturers, they are moving to be ready for this. They can install whatever range of lighting they want in a cab if it's promoting alertness. They can install cameras to monitor eye movements. They've got spots in new ambulances. So they are looking ahead at all these things that might come down the path with NHS. So this is what sits there in the literature, but of course the question is, will it work in the ambulance sector, and how can we work with the ambulance sector to try and turn this into practice? So I'll take you through kind of the questions and how we're doing this, because this for me is at the heart of what we should be doing and pushing ourselves to do in the NHS in terms of how do we actually turn this into practice. So this is just an example of kind of some of the ways we're unpacking when we get a no. So, okay, so you think that won't work now, but why is that? Is it because you don't think the staff will support it? You don't think management will support it? You don't think we can afford it? You don't think that you'll be able to kind of work with colleagues with this kind of new way of approach? So we're kind of unpacking it down to sort of specific reasons as to why this may or may not work. Interestingly, when we kind of presented these sort of 20 intervention options, there was a lot of endorsement for people could see how this would make a difference. When they identified barriers, interestingly, it wasn't often, I don't think I could do that. It was perhaps a little bit less faith in their colleagues' ability to engage with it, which I thought that was quite interesting. I don't know if that's kind of an ambulance sector thing or if we'd see that in other parts of the NHS. But also, of course, sufficient training, sufficient resources, and you've got to have management backing. So again, a lot of this is there's no surprises there, but unless you break it down and ask that, but exactly why won't this work, then you don't know what to do in response. When we sort of map that against our kind of 20 options, kind of no-brainers, people endorsed, education and training, health and wellbeing, accident investigation. These are things they're doing already. They've got the infrastructure to kind of enhance and expand what they're doing. Things that are more novel, more expensive, technology-based are the ones that they really kind of wanted some in-depth discussion around. So they were the ones we kind of took through to some further work. And just kind of in our sort of very initial conversations, I thought these kind of quotes sort of really stuck with me. We're coming to that sort of napping. Sleeping on duty has always been regarded as a sackable offence, whereas we have other ambulance trusts that are providing quiet rooms, beds, lounges, massage chairs, things to help people, if they're lucky enough to get a break, to actually have a bit of proper downtime. Management doesn't care about sleep issues as they no longer work night shifts. I think that's a really important reflection as well. And of course, when we're talking about sort of journey management, like you can have a rest before you go home, or you can be subsidised for public transport, all of these things have challenges, and of course we know a lot of people it's just not possible to use public transport. So with our colleagues in the Health and Safety Executive, we took this through a series of workshops to look at why won't it work, what difference could it make, are there any drawbacks, what are the interdependencies, how do we package this together into a fatigue risk management approach. And again, we're getting kind of some really powerful quotes. Trusts may not have fatigue management policies, they may not have a great deal on sleep in their staff wellbeing policies, but they are trying to unpack some of these issues. They are trying to move forward and see what they can do. They would appreciate a sector-wide approach. They think there will be support for management, perhaps the staff might need to be brought on board. Biomathematical-based approaches, fantastic, but we're struggling just to get our basic rotas kind of organised. So let us do that first, and then we'll think about fancy ways of doing it. And of course, particularly when we're talking about mental health issues that are impacting on sleep, we've still got some work to do around how we encourage staff to come forward with that. What would be the advantages? Staff would feel more in control. Staff would feel supported. It'll help with retention. These are all really important, concrete things that the NHS and social care workforces are struggling with at the moment. Clear and transparent ways of determining shift patterns, reducing sickness absence, cost effectiveness. All of these are kind of potential benefits that could be seen, and to keep people sort of motivated in this space. What do we need to know? Again, here's some examples. Engagement with staff and staff representatives. Clear communication, particularly with staff who are very, very wedded to their 12-hour shifts. We think of this as we'll never be able to move away from 12-hour shifts in the ambulance sector, but actually one trust did. They moved away from 12-hour shifts overnight and only have 10-hour shifts now, and they did that through a long process of consultation and through people looking at their own data through wearables. So it can be done. So we got our feedback for our 20 options about will it really work. Then we've gone to senior leaders. So this is people at director, deputy director, chief executive level to say how can we kind of make this work in practice for your trust, for your portfolio. So we're saying what's already been done, why has it worked, why has it not worked. We're very interested around the culture of fatigue as a contributing factor, or where there is not even direct pressure not to report fatigue as a contributing factor. How can we kind of work with the trusts around this? And of course, no surprise, there's a real difference in maturity in terms of approach to this. We've just started the conversation, right up to we're here, we're there, we're already moving forward. Let us know how you can help us push this agenda forward. And what are they already doing? And what sort of impact are they seeing? Looking at task-related changes, looking at education, trying to link this into their wellbeing efforts, particularly around that kind of mental health space. And they are getting reports that this is making a difference to staff. Not at the level of sophistication we see with data use that Phil's presented, which is just amazing, but they are getting kind of feedback that this is starting to make a difference for staff. What would help? Shared responsibility kept coming up time and time again. It'll be interesting what sort of feedback we get when we go out to frontline staff. They want support to help staff report fatigue as a contributing factor. That's why I'm kind of so excited by the work that Laura and her team have been doing around the fatigue trigger tool to help staff come forward and have the confidence and that they feel supported to say, actually, that near miss, I think it was due to a microsleep or whatever reason. So where are we going next with this? For us, it's about developing those suite of options for a trust to say, we know you can't do everything. We know the EasyJet system is probably a step too far at the moment, but here's the information that you need to make your decisions. Here are the strategies we suggest that you could apply to break down those specific barriers that you're encountering. And this is how we think it'll make a difference to your staff and patients. And when we've done that, for us, our next piece of work is then to understand, and perhaps we might kind of touch on this afternoon, is this an approach that we could use for other parts of the NHS and social care. This is an out-of-hospital setting, mostly. I'm very, very interested about our social workers, our community nurses, our people who are out there driving long distances, long hours, very long shifts. This conversation is kind of not even there yet for those workforces. For obvious reasons, we've had a lot of hospital-based work. We're now moving into community in emergency care with ambulance. What comes after that? And I'll finish there. And please do get in touch if you want to stay up to date with us, because we are running for another year, so we've still got a lot of work to do, but love to hear your thoughts and feedback. Thanks very much.
Thank you. I think we'll all agree it's really exciting. We've got a couple of questions.
Thank you very much for an excellent final presentation. So we have one question in the room here.
Thanks. My name's Claire Land. I'm from the Care Quality Commission. Firstly, just a comment. I think it's really interesting that it's the ambulance services that are doing this, because we know from the NHS staff survey, etc., that there are particular issues around culture in ambulance trust, so that's really good. I just wondered, to what extent are you looking at fatigue in relation to driving as opposed to clinical patient safety?
Yeah, absolutely. So we have looked at that in our interviews, because when we went to talk to sort of, the directors of safety and risk, they said they were concerned about two things: driving risk and medication errors. And could we work with teams to do that? So absolutely. So we've just got a little bit of kind of early, I guess, indications around how trusts might be thinking about driving risk, because that is something obviously that is particularly prominent for some roles and sort of a recognised risk, even though there's not kind of much concrete action being done about it. But absolutely, that's one of the things we'll be looking at when we go out with the frontline teams. Yeah.
Thank you very much. And Rich, our online community?
I'm going to be greedy and ask a two-parter again. So one person's asked basically where you think you are in relation to other blue light services, whether you're ahead of them or whether we're catching up within healthcare. And then the other comment that somebody made online was that some industries are moving away from fatigue management and more towards managing alertness. And I wonder whether that chimes with I had noticed you had on one slide about the dynamic fatigue risk assessment, and whether you could tell us a bit about that.
Yeah, absolutely. So it's an interesting question about how we're sort of tracking with blue light services. I've been doing some work and conversations with fire and rescue. They say we're quite ahead of them, but their shifts are really very different to what's done in health and social care. Police, similarly, some areas they're ahead. They've got some incredible tailored sleep support resources, so kind of online resources that staff can engage with, but they're not doing this systemic stuff. So they're kind of wanting to see how far we get with this systemic stuff. And of course, I knew this was happening. What was the second part of the question?
Look, it's my fault for doing that. Normally I forget what I'm talking about halfway through responding to a question. It's about alertness management and your dynamic fatigue risk assessment.
Yeah, absolutely. So yes, the answer is yes. It is kind of couched around fatigue, but the flip side is thinking about alertness and safety for practice. So in some of our kind of preparatory work, we did do some sort of early scoping of doing things like psychomotor vigilance testing at start of shift, during shift, as a way to actually think about alertness. Really mixed responses around that, obviously for kind of sort of practical, but also, you know, a bit of a response was, with all this monitoring, well, what are you going to do about it? Are you going to stand me down? Are you going to send me home? No, of course not. So why on earth would I bother to go down this path of trying to do wearables or whatever? And I think that's the key. If staff don't have trust or confidence that something will be done about it, do we want to go down that path just for the sake of saying, yeah, we thought it was pretty bad, we know it's bad. Sorry, yeah, we know it's bad, but there's nothing we can do. The system's against us. I think we have to think about where best to sort of put our efforts into so that we can have sort of realistic expectations for staff about what might change.
Thank you. We've got time to squeeze just one more question in the room.
Hi, I'm Kirk from the General Medical Council. Firstly, just to say, really great, interesting stuff. Love the acronym as well. Just when you were saying about some of the trusts were much less engaged currently and some were much more advanced, is there anything that sort of comes along with that, or any observations about what might help people be more engaged?
It's a really, really interesting question. I think I'd probably give the kind of analogy of staff mental health and wellbeing, which is actually where I come from, which is why I keep talking about mental health, because that's my background. 10, 15 years ago, we would have conversations about, we can't ask people about depression, you know, what if that, you know, triggers people having depression, we've got no response, we can't get there. We tackled a lot of that, it's not meaning that we've solved it, but it's a very front and centre conversation now, and you will never get a chief executive, a senior manager saying, no, we don't have time for mental health. We know what we do sometimes impacts on mental health, but you would never have anyone say, we don't have time for that. I think we'll get there for sleep and fatigue, but the way we'll get there, I think, is to break it down for trust, to say, you don't have to do an EasyJet, but you could do these 3 things. And this is how you do it, these are the steps you take, and this is the sort of difference that you might see. And I think we'll start to change the conversation. Some trusts are just still in firefighting mode, completely get that. Some of the responses was, we just want to get our rotas right, we'd just like our staff to have a break on a 14-hour shift. So I completely understand that. So we need to kind of have these examples of best practice, capture what they're already doing, because there's some incredible stuff being done in individual trusts, in individual stations. So if we can kind of amplify that, I think that will be a really important part of the conversation.
Great, thank you very much.
So I'd like to say a huge thank you to all our speakers, and thank you to everyone who's joined us online. I'm going to hand over to Ted Baker to do some closing remarks, who's our chair designate, coming in from HSIB to HSIB, which we are hopefully moving to in October, but I'm going to hand over to Ted to close us. Thank you.
Thank you, Laura. And yes, HSIB, the new organisation, will be up and running later on this year. And I think today has been a great start, looking forward to what we can achieve. And what we can achieve as an organisation we'll only achieve in partnership with lots of other parts of the system. So I very much welcome everyone who's joined us here in the room today and everyone who's joined us online. It's been really dynamic, the questions coming in, and fascinating, and the interest in this. I've been to many conferences and meetings over the years, but I think this may be one of the most important. There's nothing more important than patient safety, and it is very clear to me that we do not yet understand the significance of fatigue in patient safety. 20% of rail accidents have fatigue as an issue, same in automotive. How many in health services? Do we know? Well, I think the speakers today have made it very clear that it's significant. But we need to know, and we need to know what we're going to do about that. So I think this is a really important start of something that we need to do together. And it's really important we work on this together. Can I say a big thank you to all our speakers today? They've given up their time. I have to say the talks have been fascinating. I've learned a lot. I shall certainly be reviewing them on the recording because I think there's so much richness in them that seeing them once is not enough. But it is really fascinating what they've told us, and it is a real challenge for what we can do better. As I say, thank you to everyone who's joined us for this session. I hope you will see it as important as we do, and I hope everyone here and online would join us in finding the way forward for this. Can I say a big thank you to Laura, who's been introducing this, who's been organising it. A big thank you to Andrew and the education team, who've been really influential in this. I understand Lauren Turner has been particularly important in organising this meeting and reorganising this meeting. So Lauren, I don't think you're here with us today, but thank you very much if you're watching the recording. And can I also say a thank you to our comms colleagues who've been really important in publicising this and working with us today, and colleagues from our investigation teams as well. Thank you so much for the work you've put in. This is the start of our work, not the future. I started in medicine many years ago, and it was very much the culture of the hero healthcare worker, and fatigue was seen as a weakness. And Emma quoted the Australian study demonstrating it's not just a UK issue. Often a tired doctor is better than no doctor at all, which is a rather depressing conclusion at the end of a study on fatigue. I think we can go much further than that. I think we need to challenge that culture, and challenging that culture is very clear an important part of the way forward. But we've learnt so much today of the work going on in other industries that are way ahead of the game on this. And we need to learn from them, but we also need to learn from the work going on in anaesthetics, and anaesthetics, as ever, is ahead of the game on patient safety, but also the ambulance services we just heard about from Christy. I think there is an awful lot we can do learning from one another and understanding the impact of fatigue on patient safety better. If we can understand it better, we can introduce the right solutions. Let's all do that together. Thank you.